I'm Nicole Abreu-Shepard, and I have the pleasure of introducing Dr. Zeitler. We had a chance to get to know each other a little bit yesterday at the Picori session, and he is a renowned expert in endocrinology, and he's from the Children's Hospital of Colorado, and also a professor at the University of Colorado, correct? Yes. And he's here to talk to us about endocrinology issues, which I am very interested in for my own daughter, and I'm sure everybody here is for the same reason. And I think we'll have a lot to learn. Are we going to have time for questions too? Or?
I hope so.
Okay, good. Well, let's get started right away. So we do.
Yeah, I'm kind of antsy person.
Yeah. We're going to sweat in this room.
Yeah, I was going to say that I'm impressed by your commitment to sit in this room at this time of the afternoon. It's warm in here. So I'm pleased to be here, and I appreciate being invited to chat with you. Sometimes this is an area that's not necessarily paid attention to, and yet it can have significant impact on your kids' quality of life. And one of the things that is sometimes frustrating is that most of these problems are treatable, but you have to recognize them before you can treat them. So let me start by saying how many folks in this room are currently their child is currently being followed by an endocrinologist? So maybe 20% or so. How many have been seen by an endocrinologist in the past? Discharged without problem? Is that or just finished treatment? Just found not to have anything wrong? Okay. And referred just as part of routine, or there was a concern? Parent requested, okay. Couple of fractures. Oh, okay. I'm actually not going to talk about that, but that's quite interesting. Okay, great. So, and then how many people have never heard of the idea that an endocrinologist should be involved in the care of kids who've had epilepsy surgery? Okay, so we have a pretty broad range here. Excellent. Well, let me start with a caveat. There is really very little published information on the prevalence of endocrine problems following hemispherectomy or any other large epilepsy surgery. So much of what I'm going to talk about is really going to be based on some limited clinical experience, and most importantly, on other situations that have analogies, other kinds of brain surgery, other situations in which hydrocephalus occurs, to try to get an idea of what might happen, even though we don't have a literature which to base this upon. And also what I really want to do is give you guys an understanding of the system so that you can understand what the questions might be and what questions to ask, and get enough ammunition that you can take to a visit with your physiatrist or to the endocrinologist so that you have an understanding of what all is going on here. Okay, so the first thing is, does this have a pointer? Maybe not. Did it have a pointer? Do you know? Somebody use a pointer? But you probably can't even see it, right? Okay, yeah, it's getting brighter actually as I hold it. Okay, so the first thing to understand is the most of the problems that arise, except for fracturing, which is really a separate issue that I should have thought of but hadn't put in this talk. Except for fracturing, the issues really arise from the hypothalamus and pituitary. And those are located right here at the base in the very middle of the forebrain. And so you can imagine right away why this might become an issue, right, in kids having cranial surgery. This is kind of a cartoon of what this looks like. The hypothalamus is this part of the brain right here that is then connected with a bit of a stalk to this structure that sits down in a bit of a bony saddle that contains two parts, the anterior pituitary and the posterior pituitary, and we'll talk more about that. So it's in a vulnerable position. The second thing you need to know, and don't worry about all these drawings, they're just meant to show you that this is complicated. But so here's the hypothalamus. And the hypothalamus, again, is that the very bottom part of the brain below the third ventricle. And the hypothalamus is involved in the regulation of secretion of hormones from the pituitary. And what this drawing shows you is that it is receiving inputs from many higher central nervous system centers. Spinal cord, midbrain, cortex, basal forebrain. The hypothalamus is not an independent little area that's making decisions by itself as to what kind of regulation there should be for the hormones, right? It's receiving lots of inputs. And so you can imagine that if these inputs become abnormal, then it's not surprising that some abnormalities may then occur in the hypothalamus function. Does that make sense? Okay. The next thing we need to know is that the hypothalamus, so I showed you this picture, there's that stalk that connects the hypothalamus to the pituitary. That stalk contains two different kinds of things. First, it contains neurons that have their bodies within the hypothalamus that extend down into the posterior pituitary. These are neurons that make a hormone called vasopressin. I'll come back and discuss that with you in a moment. So there's neurons that actually extend down into the posterior pituitary. So in a sense, the posterior pituitary is a bit of nervous tissue, and that releases hormones back there. In addition, the hypothalamus releases hormones within the hypothalamus onto a little tiny circulatory system that extends from the hypothalamus into the pituitary and bathes the pituitary with signals that are coming from the hypothalamus regulating secretion from the pituitary. Does that all make sense? Okay. What about the pituitary? I think of the pituitary as the Amazon.com for regulatory hormones, right? People used to talk about the pituitary gland being the master gland. Well, it's not. It's actually in some ways quite passive. It's really better to think about not as a master gland, but as a warehouse. It's responsible for manufacturing and secreting of hormones, but it's under the regulation of the hypothalamus, which is under the regulation of higher centers. So you can see immediately, no surprise, that you might in fact see problems with pituitary hormone secretion in people who have had central nervous system surgery. Make sense? So from an endocrinologist's point of view, this is kind of duh. Okay? You would expect this to happen. So what does the pituitary make? The pituitary makes sort of 6 basic hormones. Prolactin, which is involved in lactation and milk production. Generally, you don't see deficiencies. In fact, what you can see with disruptions higher up is elevated prolactin. So you can actually get lactation occurring in the absence of pregnancy if there's been disruption. Growth hormone, obviously, which is involved in the regulation of growth, but it's poorly named, and it does more than make you get taller. It also builds muscle, it decreases fat, it builds bone. It's better known as anabolic hormone, which is why the weightlifters abuse it. It's not to get taller, it's to get bigger. Thyroid stimulating hormone regulates the thyroid gland. Thyroid hormone is involved in expression of many genes, but the most sort of obvious thing it does is regulate metabolism. So if you have too much thyroid hormone, everything's too fast. If you have too little thyroid hormone, everything's too slow. Okay? ACTH regulates the adrenal gland and the production of cortisol, which is a stress hormone that's necessary. In some ways, what it does is kind of tamp things down so that your body doesn't completely lose it when there's an infection or some other trauma that's occurring. And then there's a pair of hormones called gonadotropins, LH and FSH, that are responsible for regulating the gonads, the testis, and ovaries. So we'll go through each of these to some extent. In addition, the posterior pituitary, the one that has the nerves coming down into it, makes this hormone called vasopressin. which is involved in the regulation of water balance at the kidney, okay? So that's where I want to start, because that is usually the first thing that occurs when there has been surgery, is an abnormality in vasopressin. It's usually the first way you run into this. Oh, sorry. So talking about parallels, what would you expect, okay? If you look at other situations where there's been brain surgery or hydrocephalus, what would you expect? Well, we know from surgery of this area, the basal forebrain or hypothalamus, from brain tumor literature, that you'd expect anterior pituitary deficiencies. You might see abnormalities in water regulation called diabetes insipidus. We'll talk about that in a moment. But in addition, thirst resides in the hypothalamus also. So you might expect to see abnormalities in thirst in patients who've had surgery. Excessive appetite. But in addition, alterations in energy expenditure. So it's not just that the hypothalamus causes increased appetite, but it actually changes the way in which the body burns calories. Temperature dysregulation, dysautonomia, flushing, abnormal regulation of circulation, that sort of thing. All of this is being regulated within the hypothalamus. And you can see some characteristic behavioral disorders in patients who've had hypothalamic disruption. In hydrocephalus, you typically see things like precocious puberty. And again, abnormalities in appetite, energy expenditure, and development of obesity. So this kind of gives you the universe of what you might expect to occur in somebody having central nervous system surgery. So let's start with diabetes insipidus. So diabetes insipidus, the word diabetes just means lots of peeing. So there's two big kinds of diabetes insipidus. There's diabetes mellitus, mellitus meaning sweet, because that's how they, believe it or not, that's how they used to tell, it was sweet because there's sugar in it. Diabetes insipidus, insipid meaning weak. So it's a weak, excessive urinating, okay? So what that means is that you're having too much water in the urine. So arginine vasopressin is the hormone that's responsible. It's a little tiny thing. It's synthesized in the hypothalamus, and it's actually transported down to the pituitary through the stalk. And that stalk is quite fragile and is subject to disruption. We can see problems with diabetes insipidus in kids who've had brain surgery. You can see it with kids with hydrocephalus. You can see it in kids who've had car accidents where there's a trauma to the brain going back and forth, can actually cause shearing of the stalk. It's released in response to decreased blood volume. What does that mean? So if you become dehydrated, you don't drink on a day like this, right? You pee less, right? And your urine gets dark and yellow because it's being more concentrated. More water is being pulled in. So when the blood volume decreases for any reason, ABP is made. It tells your kidney to hang on to water. So what's put into the urine is as concentrated as it can be. You see this every morning when you pee and your urine is yellow, unless you've been up late drinking. If you can't do that, if you can't make this hormone, what's going to happen? You're going to continue to make urine even when you shouldn't. Does that make sense? Okay, and this is why this happens. So what does it do? It promotes the insertion of water channels into the duct, and it increases thirst. Okay, so it's, right, makes sense. Hang on to water and get thirsty. Okay, so here's actually what happens, just a little bit of physiology, just remind you maybe of high school biology a little bit. So if you remember, the kidney generates a gradient so that it becomes more and more concentrated as you go down through the kidney, so it can pull more and more water. It's like the cooling loops in the back of your refrigerator. You can generate a colder and colder area as you go down the loop. What happens is, what AVP does is it inserts itself into the duct so that water can actually go through the cell, right? Normally, water can't get through a cell because it's surrounded by fat. Water can't go through fat. So this creates a way for water to get through the cell and so that it's drawn back up again. If you can't do this, you're going to lose all your water. Does that make sense? Conversely, if you have too much of it inappropriately, you are going to hang on to water even if you don't need it. And so your blood volume will actually expand inappropriately. You become overhydrated. And in the clinical setting, what that looks like is your sodium falls. You get hyponatremia. Conversely, if you're dry, your sodium rises. So sodium, when your doctors measure sodium, they're not measuring sodium, they're actually measuring water. Okay? A high sodium means little water, a low sodium means too much water. Okay, so what does it look like? Diabetes insipidus looks like excessive urinating, excessive thirst, and, however, normal to mildly elevated sodium as long as the person has free access to water. Because they will drink and drink and drink and drink and drink to keep that sodium from rising because it's a very uncomfortable signal to thirst when the sodium is high. So after surgery or an episode of hydrocephalus, water regulation requires careful observation of urine output because the sodium may not change unless the child is in a situation where they don't have access to water or where the doctors are providing the water irrespective of thirst and volume, okay? It may be variable, and as I'll show you in a second, it may be changeable. It requires ongoing reassessment because things are changing. And in the immediate situation, there's something called the triple response, which may be your first exposure to this. How many of you experience problems in the ICU after surgery with water balance? Yeah, so 20% or so. So it's not an uncommon problem. So what is the triple response? Okay, so the first thing that happens is diabetes insipidus. This is because of acute, if you will, shock to the system, right? Something has happened and things just aren't working right, and the hormone's not being made properly. It may last anywhere from 24 to 48 hours, and it may resolve. It may turn into a second phase of excessive secretion of hormone because now the damaged cells have actually died and they're now releasing hormone in an unregulated way, or the diabetes insipidus may be permanent. It's going to have increased urine output and a rising serum sodium with a dilute urine. The treatment usually is increasing the fluid at this point. The problems can be nursing problems. The fluid rates may become incredibly high. Somebody's nodding knowingly. The fluid rates can become incredibly high and almost impossible to keep up with. And because that fluid has to have some sugar in it to keep your red cells from breaking, you may become actually hyperglycemic. Blood sugar may rise. That may limit your ability to treat this with just fluid, and it can just become a problem. So there are drugs you can use. Most commonly, Vasopressin is used either as an injection or as an infusion. In the acute situation, it's short-acting and it helps take care of the problem. The second part of this is unregulated AVP vasopressin secretion. Some people refer this as the syndrome of inappropriate ADH secretion, or SIADH. It's not really a good name, but it's still used. It usually occurs following the period of DI and is thought to reflect damage. It looks like a sudden decrease in the urine output. The urine becomes very concentrated, and if the fluid management isn't appropriate, the serum sodium starts to fall, and you can have a frankly low sodium and have a seizure. This requires careful management. The treatment is actually fluid restriction. You can do some other things to force the body to get rid of water, and they can also be helpful. And then the third part of the triple response is longer-term diabetes insipidus. This usually follows a period of SIADH. or the original immediate diabetes insipidus, okay? And again, this is gonna look like rising urine output that's inappropriate for the clinical situation, a rising serum sodium. The urine is gonna have a low, it's not concentrated. Specific gravity is a way that doctors measure how concentrated the urine is. So to have a low specific gravity. And it's gonna be treated with increasing fluids or medications. So far, so good? Okay. So once established, why would you use medications versus fluids? Really, it's it's quality of life. People with DI can just drink, but they really drink. I don't know if any of you guys have experienced this. Anybody's kids had DI for any long period of time? Good. It usually, I'll show you the data suggests that in this sort of surgery, it usually is transient, but it's terrible. People are really, really thirsty. They're up all night, every 2 hours drinking. Their sleep is disrupted. They're peeing all the time. So it's a problem. And so generally, you want to use drinking. You want to use medications for comfort. And we have good therapy that's going to treat this. In the interest of getting to things that really count, because they're more likely to happen. Most of this is transient. I'm going to flip through this. I think you guys are going to get slides from people. Yeah, so it'll be in your slides, but this is not as relevant except in the immediate postoperative period. Most of you already been through that. If you know people who are about to have surgery, my message would be have them watch the neurosurgeons like a hawk. Because this is somewhere that I hate to say it, where they just don't get it. They're not watching for it. Kids are different than adults. In a lot of places, the neurosurgery residents are adult neurosurgery residents rotating, and they don't get this. And we've often I had one family, the mother, it was a kid with a brain tumor, and every time the kid had surgery, she would, be like a hawk. And one time, the neurosurgeon came in to change the fluids, and she threw herself across the kid's bed and said, "No, not until you call Endocrine." And so, because the kid had a seizure once before, because they just didn't get it. So, just that if you see other folks who haven't had surgery yet, just make sure that they're paying attention. Okay. So let's move on to more chronic stuff. So I want to first talk about pubertal abnormalities. How many folks are having some early puberty in your, yeah, about 10% maybe? It can be any age. It depends on the age of the surgery. But sometime early puberty would be defined as a girl before, it depends, say before 7, a boy before 8 would be considered to be early. And those are uncommon at that end, but they're not necessarily abnormal. So it's much less common actually to see decreased function. We don't usually see kids lose function of the ovaries and testes. It can happen, but life has a way, and somehow these functions are pretty robust. Amazingly. So you can see decreased function, and that's going to look like either delayed puberty or arrested puberty, boys whose testosterone don't quite get up to a typical adult level, girls who don't quite establish regular cycles, etc. You may get menstrual irregularities either right away or later, or sort of early loss of regular periods. So you may see that. But more commonly, interestingly, is premature precocious puberty. Is much more common in central nervous system disruption. Now, why would that be? We don't really know, but what I can tell you is that the system is turned on at birth. So little boys have testosterone levels at about a month of age that rival those of young adult males. Little girls have estradiol levels that at a month of age rival those of young adult women. And then the system is shut down and turned off. We do not know what exactly it is that shuts off the system. It's known to be higher up. It's a regulation of the pituitary, of the hypothalamus, by higher centers. That's as much as we know. But if you think of it that way, then anything that disrupts those higher centers is likely to be associated with early onset of puberty, right? It starts to make sense. And so you see this in kids with epilepsy who haven't had surgery. You see this in kids with CP, with spina bifida. You see this in kids who've had just developmental delays, CP, etc. Any kind of CNS disruption can be associated with early onset of puberty. So we don't understand it. What about in hydrocephalus? Again, nothing in epilepsy surgery that I could find. Well, there's something. At the very end, I'm going to show you like one line in a paper. But what do we know in hydrocephalus? So this is 114 kids. This is way back in 1996. I think these were mostly spina bifida kids, if I remember correctly. And what did they find? So testicular development was advanced. Male and female pubic hair development was advanced relative to the controls. The mean age at first period was lower in the patients than in the control kids, and lower than their mothers, so it's not just genetic. Testicular volume was higher at all ages, so they're more advanced at any age. And the prepubertal kids had levels of hormones that were higher, suggesting that they were sort of on their way to having earlier puberty. So that's it. There's the literature. But we do know that this is common in any kind of central nervous system disruption.
Real quick, do you happen to know if the hydrocephalus people all had shunts, or were they all?
They were, I think they were mostly shunted. Yeah, I think so. But the issue is they had hydrocephalus, they had increased pressure before they were shunted. That's thought to be kind of the mechanism, not the shunt, but the pressure. Yeah. So how do you diagnose and monitor precocious puberty, which is what you want to know, right? In our minds, all children at risk should be evaluated by a knowledgeable somebody at the first sign of puberty. Now, does it have to be an endocrinologist? No. Endocrinologists are going to be more likely to pick up nuanced abnormalities at this point. It's what they're trained to do. But you can't it's hard to get in to see an endocrinologist in some places, right? So a smart pediatrician can do this. A rehab doc who's decided to educate his or herself on this can do this. But somebody has to be paying attention, know what to look for, and be monitoring this. What does that mean? It means a good physical exam, looking at pubic hair, looking at the penis, measuring the testes. That is how we know if a boy is in puberty. You can't tell by just looking or asking, by the way. I've seen that. The kid denies pubic hair. It's like, he's not going to tell you. Yeah, my favorite is, a 14-year-old boy denies erections. It's like, right, with his mother in the room, right. So, it requires an exam, and it means that somebody has to do the exam. Too often I see physical exams say puberty deferred. There's no reason to defer it. It's part of the routine physical examination. Get your kids used to it. It's not a big deal. It takes me 20 seconds while I'm chatting with the kid about whatever they're doing outside of school. I'm done, we're over. So it's not a big deal. I think it's often made too much of. You can do some blood tests. You need to be careful how you interpret them. You need a particularly sensitive test called LH because these values are very, very, very low early on, and so you have to be able to pick up very low from low, and so it requires a special test, and it requires some knowledge. Oh, and this shows this. So if you look at this level of hormones, this is a hormone called LH. Before puberty, it's pulsing, but very, very low. And then as you get into early puberty, you start to see more, but nothing like you see in adults. So if you use an adult assay, it's not going to see. It's going to have, it's going to say less than 2, but these kids are functioning around 0.3, 0.4. Now, there are assays that can see this, but it has to be the right one. Okay, that's why maybe an endocrinologist needs to be involved, or a good pediatrician who's asking questions of whoever it is they consult with. We did this. There are some other things you can do. A bone age. You may hear people talk about getting an X-ray of the hand. And I'll show you what that tells us in a second. There are some stimulation tests you can do, and occasionally we get a pelvic ultrasound if it's confusing in girls to see if the uterus looks like it's developing, but it's not usually necessary. So this is what a bone age is. Bone age really is just a picture of the hand. Somebody, amazingly enough, realized that, in fact, that the bones of the hand and the rest of the body, but the hand reflects it, develop in a very stereotypical, predictable way, and they spent the time to sort of figure out what the hands look like of a typical 3-year-old, 4-year-old, 5-year-old, 6-year-old, and this is what we use. Now, keep in mind that, not surprisingly, these are the hands of middle-class white kids, right? It's what we got. It seems to work most of the time, but there are some problems with this data set. And what you see is that there's more bones showing up here. The ones in front can see that looks like there's little bones at the end of those fingers. There's not really little bones. Those are the same bone, but it's not all been calcified yet. So the X-ray doesn't see it. So that all appears in a very typical fashion, and you can say, well, this is the bone age of a typical 5-year-old. This looks like the hand of a typical 15-year-old. Okay, and that can be quite useful because, in fact, puberty generally starts at a bone age of 12 in boys and a bone age of 10 to 11 in girls, no matter how old they are, right? So you can be late, you can be early, you can be typical, sort of average, but that bone age is really a good predictor. It's, in a sense, a biological age. It also tells us what growth potential's remaining, right? So if the bone age is really advanced, it means you have the growth potential left of somebody much older than you, which is going to be less than somebody your age. Does that make sense? Okay. So what do? We have good therapy. These are called Gnrh agonists. What they essentially do is overstimulate the pituitary with the hormone that is a long-acting version of the hormones that regulate gonadotropin, LH and FS secretion. So the pituitary says stop, 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 and shuts down. And it's really very effective. It stops puberty always. Sometimes you have to fuss with the dose, but it's really not much fussing. There's a variety of them. You can give it in the nose, you can have injected, you can have an implant. They are all equally effective. It's going to depend on your doctor's and your family's preference and your insurance company's preference, because these are extremely expensive. There are no clinically relevant side effects. Puberty comes back. We've been using these for 30 to 35 years. People have gone on to have pregnancies. There are no clinically relevant side effects. You may read about decreased bone density. Yeah, but that's reversible. As soon as you give the steroids, let them go, the bones respond. Some people say there's increased fat. It's not really been very clear. Women, unfortunately, gain fat during puberty. That's sort of attributed to the Lupron, to the medication. There's no good evidence in randomized trials that it does really increase fat. Okay, any questions about puberty? Okay, let's move on. There'll be time for questions. Yeah, yeah, it's okay.
When you say to stop it, I mean, you're talking about it like the age 5 or age 6 or something, like when it's way too precoce.
Yes,
like
yes.
Okay.
Yeah, although sometimes...
9, 10, just like early, there'd be no...
Well, okay, it's a very good question. Sometimes we do discuss with people if the child is extremely delayed emotionally, we will intervene in that circumstance. They may, quote, not be ready. if they're functioning at the level of a 3-year-old or a 5-year-old, or particularly if there's a feeling like they are making progress and another year or two might make a difference, we will discuss it. Yeah.
Our neurologist said the opposite. She said, "Look, Rick, let's go, let's get it done." Is kind of what she said when we talked about it.
Yes, that's also, I mean,
Different school of thought, maybe.
it's up to the family. It's not a different school of thought. I mean, I think this is up to the family. If the kid is sort of doing okay and you can handle menses, which is usually the issue, it's not usually the boys, it's usually the girls where it's an issue. If you can handle menses, then fine, get it over with. That's okay. If height doesn't matter, because you may lose some height, but that may not matter depending on the circumstance. And in fact, you may prefer a smaller height, and that's also reasonable. And what we would generally do in that circumstance would be to get through puberty and then start some sort of menstrual suppression with continuous birth control pill, for example.
That was going to be my question.
Yes.
Like, you were trying to be preventative, but then you somehow didn't get it right, and puberty kind of started. Could you slow things down?
You can stop it. Yep, you can shut it down. Oh, I'm sorry. Yeah, what she asked, I think, was do you have to get it before it starts, or can you sort of stop it when it's partway through? And the answer is you can. You can stop it. These are good drugs. They will shut the system down.
I understand the benefit of getting ahead of it.
Sure.
Everybody,
Yeah.
for all of us, but if it wasn't the case, that's good to know.
Yes, no, absolutely. These are one of the reasons I love being an endocrinologist is that we can play a lot, and in generally don't have bad effects, side effects, because these are just natural. We're doing a little engineering here, but these are really pretty much natural hormonal agents that we're changing the timing of, so we can actually have a fair amount of control over this stuff without really causing trouble.
Do these hormones, I heard someone mention Lupron or something.
Yes.
Can that affect them in other ways, their side effects? Because I know
No, I mean, they will stop puberty.
behaviorally, like, have you seen it with kids with special needs? Does it make them more aggressive?
No. I would say that generally what you see is the opposite. Like you have like a boy who's going through puberty, is kind of emotionally not prepared. They might get a little bit of, being Rambo and having the brain of a 5-year-old may not be such a good thing, right? And so I've certainly seen families who say, we got our little boy back. And so they can certainly do that. Now, that's not a permanent solution, right? But it is something that can be done until the family's ready and et cetera. Did you have a question?
Yeah, I was just going to add, like, what do you do for our kiddos? I know some of us have kiddos that are on antipsychotic medication.
Yes.
So Abilify, Risperidone. How does that play into all this with everything?
You guys are good.
I'm sorry.
I hate talking to groups of families that are medically sophisticated. No, it's a really good question.
I'm sorry.
Oh, you're a pharmacist. Yeah, even worse.
But
No.
it's life.
Yeah, no, it's life. It's absolutely life. In general, so the question was, what about antipsychotics? And the reason that's actually relevant, it's actually a very astute question, is if you remember this figure, this one, we talked about prolactin and I kind of skipped over it. Well, antipsychotics, Abilify, Risperidone, Zyprexa, all of these drugs actually impair the regulation of prolactin, and prolactins can go high. I don't know if any of you run into that if your kids are on these drugs, but you can get prolactins that are moderately elevated, and elevated prolactin can impair the secretion of gonadotropins. So elevated prolactin can prevent puberty from progressing properly. But the reality is we don't really see it in the kind of levels of prolactin you get with Abilify and Zyprexa. I don't know that I've ever seen a kid with delayed puberty or irregular periods because of Abilify. I've seen milk production, but it doesn't seem to actually impair this. Okay, so we can treat it. Moving on to the next one. So now I want to talk about ACTH and cortisol. Cortisol is made by the adrenal gland, which sits here above the top of the kidney, adrenal, next to the kidney. Cortisol does a lot of stuff. It's involved in the expression of almost all genes, regulating them. But what matters sort of clinically is that it's involved in the stress response. So if your body is under stress, infection, fever, you have surgery, you experience a car accident, cortisol is made, and what cortisol does is kind of keeps you from overreacting, right? So when any of these things happen, you bring in white cells, they start making all sorts of stuff. You get fever, you get your circulation expands to get more blood flowing, but that can drop your blood pressure. If all of that gets out of control, you can get into shock. And what cortisol does is it helps prevent shock. Okay, so really, it does stuff during the regular days, but what's really dramatic is what happens when you're faced with a stress. So again, ACTH, which regulates cortisol, is regulated by the hypothalamus under the influence of higher central nervous system centers. There are central nervous system centers that register stress, that register fear, that register anxiety, all of which feed into regulation of cortisol. The prevalence of adrenal insufficiency following epilepsy surgery is unknown, but it is increased in hydrocephalus and midbrain surgery. So it's possible. The symptoms we talked about: acutely low blood pressure, low blood sugar, and shock. More difficult are the chronic symptoms of reduced energy, reduced appetite, reduced stamina, maybe low blood sugar. So hard to pick out from a kid with a chronic illness, right? Or a kid who's on anticonvulsants that make them tired. So this can be tough. As I said, it can be life-threatening if unrecognized. We think it's probably not that common, but it's something that has to be thought about. The diagnosis is challenging and usually requires involvement of an endocrinologist. The time when this matters is if there's an acute, serious illness. Somebody needs to be thinking about, this kid is not responding to agents to raise the blood pressure, the kid's not responding, whatever. Somebody needs to be thinking about, aha, he had central nervous system surgery, maybe. And there's no downside to giving steroids in that circumstance. They're not going to hurt anything. So screening is really not possible. You just have to be suspicious. You can do some testing. Replacement therapy is basically a hydrocortisone, which is a very weak steroid. It's safe, it's effective, and unlike everything else we prescribe, is inexpensive. Although God knows, right? I mean, things that I used to think of as inexpensive, I hear the price now, I can't believe it. And this really just takes some thought. I have no idea how relevant this is for any particular population. Okay, moving on. Growth impairment. So growth can be affected by many things. First, if the patient is hypothyroid, low thyroid hormone, they don't grow well. In a growing child, that's a very prominent feature of having low thyroid function. You can have growth hormone deficiency, and you can have abnormalities in puberty. So a kid who's went through puberty at 7 and no one noticed and stops growing at 12 may look like they have a growth problem, but in fact, they had a puberty problem. Make sense? So let's talk about growth hormone. Growth hormone, again, is regulated by two hormones that are made by the hypothalamus. Its secretion is highly vulnerable to disruption. It is probably the single most vulnerable pituitary hormone that there is. In a way, it makes sense, right? If you can design a system and say, okay, what should we let go of in a bad circumstance? Getting bigger is probably the first thing you would say, we won't worry about that. So this system is probably pretty disruptible. And we see a lot of problems with patients who've had hydrocephalus or any kind of midbrain surgery. It looks like poor growth, decreased muscle mass, strength, fatigue, increased fat, change in the body distribution, In younger kids, the faces look very immature. They don't really get that kind of mature looking. Patients who are growth hormone deficient look like little puppies. So you can sort of see that effect. It's because the midface doesn't develop. It doesn't kind of pop out, so they keep a baby's kind of small midface. It's the most common and persistent central hormone deficiency after cranial surgery in general. Who should be evaluated? Anybody who's having poor growth following surgery. We would argue that any kid who's at the first sign of puberty, you'd probably want to think about, make sure that they're okay in terms of growth hormone, because that's the final window during puberty. You don't want to miss it. And we would suggest that any at-risk girl at 10 or any at-risk boy at 12 should at least have a discussion of, is their growth good? Because puberty is going to happen. We want to be sure that you're not going to miss that window at that point. Screening, there's a blood test called IGF-1. You can't measure growth hormone because it's made in pulses, and so most of the day it's 0. So what we do is use this thing called IGF-1, which is kind of reflective of how much growth hormone's been around. It's an easy test to do. There are good norms. It's just a blood test. There are some caveats around interpreting it, but it's a good place to start. And also, somebody needs to be keeping a good growth chart. And this isn't always easy when you've got contractures and AFOs and stuff, but I would argue that at least a few times a year it's worth getting the AFOs off and getting a good height. And I know sometimes families don't want to do that, but yeah. Did you change your mind?
Well,
Did she change your mind for you?
Our daughter is sitting there. I'm not gonna. So when she was younger, they were telling her, oh, that based on growth chart, she'd probably be 5'10". Well, she only ended up being about 5'2". And but her surgery wasn't until she was older, 15 or 16. So, I mean, is all the stuff you're talking about like stuff that because like kind of post-surgical, the system gets messed up, or could it be like even just free? I guess I'm just more curious.
Yeah, so I take it you'd had epilepsy for most of your life? Certainly. So, I mean, I can't comment without knowing more.
She had a stroke at birth. So.
Yes, so, there may have been abnormal function long before, and without sort of knowing the details. Or, you just were going to be an outlier for your family, and we're going to be short. It's possible. By the way, you've got 2 inches on any woman in my family, so maybe more than 2 inches, actually. No, but that's a little complicated. Yes, I mean, this, as I said, this is really disruptable. And so there's lots of situations in which you can see disruptions of growth hormone. And they can be subtle. They may not be recognized always. Yeah, okay. And oh, okay, yeah. What I mean by that is, one of the mistakes that happens is in kids who are having early puberty, they have a growth spurt, right? And so a kid who's not growing very well, who goes into puberty, suddenly has a growth spurt, it looks like he's growing better, everybody goes, good, he's growing okay. But in fact, it's puberty, right? It's not better growth, it's a growth spurt, and it's making it look like the kid is still having decent growth, but in fact, they've had early puberty, and they're gonna stop earlier than you expect. That's what I mean. Okay, so that can make it look like the kid is growing okay. If you don't, that's why it's critical that somebody is looking at the pubertal development. It really is important. And I don't want to get into growth hormone therapy in great depth. Suffice it to say that it is very safe. It is effective when the diagnosis is made properly. It's extremely expensive. But if somebody says growth hormone, don't be afraid of it. It is, there are, of course, things that need to be talked about in terms of side effects, but they're irrelevant in most circumstances. Okay, thyroid. Regulated TSH is made by the pituitary. It's regulated by the hypothalamus. It's moderately vulnerable. Again, poor growth, increased fat, fatigue, decreased metabolic rate. Easy to screen. Yes?
Question, back on the growth hormone, we talk about deficiencies, but what about when there's an elevated or excess?
Extremely rare in children. Extremely rare. Oh, I'd love to hear about the story. I mean, that is extremely rare. Yeah, extremely rare. Thought to be related to the surgery?
I think more so underlying condition.
Okay, yeah, I'd love to hear about that. But that is extremely rare. It's much more common in adults than in kids. In fact, I can't think of the last time we worked somebody up for it. Anyway, thyroid, easy, really easy to screen for. Replacement therapy is safe, it's effective, and I would say it's inexpensive, but again, God knows. I haven't looked at the price of thyroxine lately. It should be inexpensive. It's still cheap this week. Okay, so turning now to obesity. Monica tells me that about 10% of the people responding to the registry are complaining about substantial obesity in their kids. This is an example of a child not with epilepsy surgery, but a different kind of central nervous system abnormality, had an intervention. This is a body mass index curve, this little 5-year-old, and look at this body mass index over a period of about a year, just straight up, right? So we see this. We see this in patients who've had certain kinds of midbrain tumors, who've had them resected. We see this in kids who've had other kinds of problems affecting the midbrain. Now, why? So this can be extremely severe, and it can be difficult to treat, and I'll try to explain why. We don't really fully understand what causes hypothalamic obesity, although we're getting there. We have a better understanding of the pieces that are likely involved, although we don't fully understand. There's something about abnormal. Believe it or not, the central nervous system is regulating insulin secretion by the pancreas. So there's something about abnormal regulation of insulin secretion. There's something about the regulation of metabolic rate. If you measure the metabolic rate in patients who've had central nervous system problems, it's often extremely low, much lower than you'd expect based on their body size, their age, etc. They have reduced energy expenditure, reduced activity levels. Then there's the obvious things like the physical disabilities that prevent them from being as active as their peers, right? But even beyond that, there are actually changes that are occurring because of hypothalamic disruption on the way energy is being partitioned and burned. And abnormal appetite regulation. We are getting a much better understanding of how appetite works in the brain. So in these kind of brain tumors, I don't know why I left this in. There we go. I have a feeling that I put some slides in here that I meant to sort of edit and then didn't. Because these bullets are all wrong. But anyway, hypothalamic obesity can have profound negative consequences, right? Psychosocial function can be very disturbing, especially to an adolescent. There's also the risks of metabolic abnormalities, type 2 diabetes, lipid abnormalities, hypertension, etc. So this can be a real problem. Oh yeah, this is all, here we go. So this is just a cartoon of how appetite is regulated in the hypothalamus, okay? So there's the third ventricle. I imagine you guys unfortunately sort of understand anatomy a little bit in the brain. I'm sorry that you do. There's the third ventricle. The hypothalamus is sort of like a ring around the third ventricle. In the hypothalamus are some neurons that are making hormones that increase your appetite and hormones that decrease your appetite. Okay, these neurons that are regulating the secretion of hormones that increase your appetite and decrease your appetite are also receiving inputs from the rest of the body. Okay, so fat makes a hormone called leptin. Leptin is just a signal saying there's fat here. The more leptin, the more fat. That is integrated in the hypothalamus. Hypothalamus is saying, we've got tons of fat. We don't need to be hanging on to more fat. We don't need to be eating more. Maybe I should decrease my appetite. It is integrating signals from the stomach that say I'm hungry. There's a thing called ghrelin that rises when you haven't eaten for a while. When you eat, it then falls. Okay, so it's measuring nutrient intake. All of this is being integrated by these neurons in the hypothalamus, and these then act on downstream neurons that regulate both intake behavior, food seeking, your sense of hunger, as well as the way your body is burning. You've all heard that, like, if you fast, your metabolic rate after a little while goes down, and so you can't keep losing weight, right? This is how this is all happening. It's regulating your energy expenditure. So when you have an abnormality in either in the hypothalamus or the regulation of the hypothalamus, you are going to be at risk for alterations in both appetite and energy expenditure. In addition, there's evidence of changes in fitness. And this is just a study looking at a measure of fitness, how fit you are. And this compared survivors of brain tumors to their siblings. And the bottom line is that the fitness was lower in these siblings. So your ability to consume oxygen after a brain tumor is decreased. Unrelated to the surgery, unrelated to chemotherapy or anything else. This seems to be an impact on energy expenditure by the hypothalamus. So how could you treat it? One thing that's worth considering is measurement of basal metabolic rate using an indirect calorimetry. This is just a thing you lay on a table, you get a hood placed over, and you breathe in and out, and this machine can calculate based on the ratio of oxygen to carbon dioxide what the metabolic rate is. And that is relatively easy if the kid can sit still, and it can provide information on what the kid's caloric needs really are. And unfortunately, they're often a lot lower than you think. So you may say, my kid is gaining weight, he barely eats anything. But what we often find is the caloric needs are lower than you'd expect for someone his age. Proven treatment options are limited. People have looked at some drugs that suppress insulin secretion from the pancreas because of this apparent abnormal regulation. There were some promising initial studies, but they haven't really been confirmed. Oxytocin, have any of you guys heard about oxytocin at all? The Prader-Willi community is big on oxytocin these days. Be honest, I was kind of skeptical until I heard a very famous appetite scientist recently talking about how oxytocin is involved in these pathways. And so we may be hearing more about oxytocin. It's been studied in Prader-Willi syndrome. And whether it works in anybody or depends on a specific abnormality, I don't think we know yet. There's another drug that's being studied for some genetic forms of hypothalamic obesity. Whether that will turn out to be useful for everybody remains to be seen. Metformin, a lot of people will throw metformin at anybody who's overweight. Honestly, there's no evidence that that is beneficial, except in diabetes. I would be skeptical of doing that. Liraglutide is a drug that's approved for diabetes. It's an injection. It takes away appetite. And it's actually working on one of these pathways. It's approved for adults for treatment of obesity. It's not approved for kids yet. Insurance companies won't pay for it. They'll pay for diabetes, but not for weight loss. And it hasn't been specifically used in hypothalamic obesity, but it's an interesting idea. Then there are non-specific weight loss medications, appetite suppressants, etc. Phentermine is an ancient one. It's actually relatively effective. It's a stimulant. If your kids have been on Ritalin, you may have seen that they lost appetite. It's basically working the same way. Topiramate, you may have seen as an anticonvulsant, but it actually causes weight loss. Naloxone, is what's Narcan. It's Narcan, but it's affecting the reward centers. So it takes away the joy of eating to some extent, and so it was associated with some weight loss. Bupropion, Wellbutrin, also, but mostly what you're seeing now are these combinations, and there's a variety of combinations that you can buy. They're very expensive, but the combination of phentermine and topiramate used both at very low doses is really quite effective, and we've had a lot of good luck with it in weight loss in general. We've had some kids with hypothalamic obesity of from various causes, and it's worth a try. You really do use low amounts of it, and so you don't tend to see much in the way of side effects. And then there's bariatric surgery. And the bottom line is bariatric surgery today in 2019 is the most effective approach to weight loss in adolescents. The outcomes appear to be better than those in adults, so whereas we've always said, oh no, my God, we shouldn't do this to kids, in fact, the kids do better. The complication rates, however, not surprisingly, are higher, probably because the surgeons aren't as experienced. Experience specifically in hypothalamic obesity is limited. We've done at our center, probably at this point, maybe 10 kids with hypothalamic obesity of various causes, but that's pretty limited experience. Needs to be done by an experienced pediatric bariatric surgeon with an experienced team. But if you're struggling with severe obesity, you don't really want to, I would argue that you don't want to put this off until you've got diabetes and you've got orthopedic problems related to weight and you've got hypertension and you're starting to see end organ damage. There's an argument if the kid's going to live for a really long time with the obesity to get in there early and not wait until there's so much damage that you can't reverse it. So what is known about endocrine problems after brain tumor surgery? Here's a retrospective of 207 adults. Endocrine problems in 44% of these people later on in life. Cognitive problems in 43%. 18% had no complications. Here's another list of survivors of childhood brain tumors. 19% with growth problems. 31% with weight problems. So again, not limited to epilepsy surgery. This is common in any kind of CNS surgery, and a scattering of other things. What about endocrine problems specifically after epilepsy surgery? Not much. Here's a study of 16 females with temporal lobe epilepsy before and after surgery. There were no significant differences before and after in any of the hormone levels that were measured. 4 of the patients out of the 16 had changes, 2 from irregular to regular and 2 from regular to irregular, so who knows what that means. Here's another study of patients undergoing surgery for hypothalamic hamartomas. This is a tumor that can cause seizures. They almost always have precocious puberty also before the surgery, so it's a special group. 45% had central precocious puberty at presentation. The surgery didn't help that. Thyroid levels fell in most and to clinically relevant levels in 5 of the 29, low growth hormone in 5 of the 8 when they first came, 6 of the 29 following the surgery, DI in 55%, but none went on to have persistent DI, and appetite and excessive weight gain in 45%. Now, the paper says, but don't worry, it went away in half. But that still means 25% had substantial weight gain. So in summary then, individuals undergoing large CNS surgery are at risk for development of hypothalamic pituitary dysfunction, DI, precocious puberty, adrenal insufficiency maybe, growth hormone deficiency, TSH deficiency, hypothalamic obesity. The incidence and prevalence of these had limited study. They can result in significant morbidity and reduced quality of life if unrecognized, and therefore I would argue that there's need for careful assessment of these patients before and after surgery because we have effective treatments for everything except the hypothalamic obesity. Thanks. Questions? Way in the back. I feel like Jerry Springer. I'm in Ohio, right?
Okay, my daughter now has a thyroid issue. It's minor, but she also has celiac and gluten, which they said was also part of this autoimmune thing that she has, which is causing a problem. Do a lot of people here have gluten problems?
So anybody else having celiac? Yeah, I think your daughter has an unrelated problem. Thyroid and celiac are associated with each other as an autoimmune. And autoimmune hypothyroidism is the most common cause of hypothyroidism. So bad luck, she had an unrelated problem develop. Yeah.
Our daughter probably started puberty at 7, but I couldn't find anybody to say that she was going into puberty. She's 9 now, and she's full on, acne and everything else. Are we too late? Okay.
Well, it depends what you mean by too late for what. You can certainly stop the process, for sure, and it will be effective and things will reverse. She won't go back to nothing. Breasts will diminish some. Acne will get better. But the question is what you're trying to accomplish. If she's doing okay with it, it's not an emotional problem, it's not a social problem. If height isn't an issue, then you don't have to do anything. On the other hand, if really she's struggling with it, and she's not really ready, and you're struggling more than well, if you're not ready for it, because she's 9 and the other kids aren't going through puberty, you could definitely consider stopping this. Yeah, you need an endocrinologist for that. Where do you live? You have it where? Where do you live in Montana? There's a wonderful endocrinologist in Billings. Fabulous. One of the best doctors I've ever met in my life. I can give you her. She's great. Well, she trained with us, but she's great. She came great, and we just taught her some things. She's definitely worth a visit.
I'm sorry if anyone already asked this, but as far as a child, my daughter's 7, and she's had some routine, blood work, and they said she's fine. She doesn't need an endocrinologist. Do I just rest easy at night, or should I schedule, like a periodic check-in?
Are you telling us all to go seek
This is a really hard question, guys. It really depends on the quality of the care you're receiving. If you feel like your pediatrician has heard the issue, has really thought about it, is educated on the kind of things that can happen to people who've had surgery, and they've looked at the growth chart and they say, I did 3 months of rotating with endocrine when I was a resident, and I understand all this. No, you don't need to see an endocrinologist. I just wish I had faith in all the primary care doctors out there. I mean, they just don't see this very often. And so I would say that if you have concerns that you weren't heard, or that there wasn't enough attention paid to the question, it was just, it's fine, then I would push. At least, the worst that'll happen is you'll see somebody who'll say, and you know what, endocrine folks, all the time, it's fine. We don't care if you come and you didn't need us, because we'd rather take a look at the situation and say, no, this looks good. Because what we really hate is when somebody comes at 14 and has been menstruating for a year and hasn't grown for 3 years. We hate that. So we'd much rather see the healthy kid who didn't need to come see us than not see the kid who did need to see us. So I don't know how to answer without knowing more specifics.
To add to that, I kind of was in similar situations, and we were able to kind of rest easy, but I felt like it was good to have somebody follow and have a baseline. And then you kind of go back to your mirror every 2 years, and you have...
So you went to an endocrinologist, you mean? Yeah. So you went to an endocrinologist and they said, no, it looks good. We'll see in a year or whatever. Yeah, we do a lot of that. Sure.
You have information to compare and to
Yep.
follow.
We do a lot of that. Yeah, and don't, like, sometimes I feel like families feel bad when they come in and we say, oh, everything's fine. It's okay. We're really quite happy with that, especially, yeah, it's one thing if you've got we hate it when families are short and they want a tall kid. But I don't think any endocrinologist minds when we get a medically complicated kid where the family just wants monitoring. That's what we do, and that's okay.
My son has like a heat intolerance, so when he's out in the heat and he's in exertion, he turns bright red.
Ah.
And the doctor says, oh, he's just fair skinned. But I feel like that might be endocrine related. We actually have our first appointment next week with an endocrinologist.
Yeah, so this is interesting. So,
It didn't happen before surgery.
so there's a couple of possibilities. One interesting possibility is you actually need growth hormone to sweat. And patients who are growth hormone deficient don't sweat very well. And so that could lead you to, raise your body temperature, etc. So that's one possibility. And in fact, patients with excess growth hormone sometimes sweat too much, interestingly. The other possibility is that this is this dysautonomia, where there's just dysregulation of the circulatory system. We frequently, after brain tumors, which is where I get most of my experience, see this kind of thing where kids become almost reptilian. Like if it's hot out, they get really hot, and if it's cold out, they get really cold. They have trouble regulating their body temperature. This is a hypothalamic problem. There are some studies suggesting that a drug called bromocriptine can help with this. I've used it a couple of times. I had this one kid who lived in a farm in Kansas, and whenever he went out to help with the farm, he would overheat, etc. That family felt like the bromocriptine helped. He eventually passed away for other reasons, but it seemed to help. There's some rehab. The rehab literature has some studies of bromocriptine for this problem.
So I'm probably in the minority here. And, my daughter has not had surgery yet, but we have some of these tendencies. So does the presence of abnormal tissue itself then put you at risk for these? Because I always blame the non-sweating on the Topomax, which is a known side effect.
I didn't know that. That's interesting. Huh. Interesting.
Right. You can't sweat on Topomax. So like literally she will go from in 10 minutes outside like 74-degree weather will be 99, 100 more.
Yeah.
And on the inside in an ambient room,
Yeah.
overheat.
Yeah.
100, 100.
Yeah.
We had to change like IV stuff so like don't send her home. She's not sick.
Yeah, it wouldn't, I mean, sure. I mean, I don't know, but sure, why not? Why, this is all regulated, right, by central nervous system. If there's a dysfunction, why not? It certainly could become a temperature dysregulation problem. It wouldn't surprise me. In the back.
Yes, so I noticed, and actually it's something I hadn't thought about until I sat through this lecture. You were talking about
So you slept through this lecture, you said? Oh.
I noticed you talked about ACTH and its involvement and all this. What about kiddos who, and some of our kiddos have infantile spasms, ACTH is used to treat it along with high-dose prednisone. Would that have any effects long-term on some of these endocrine issues that you see?
Yeah. I told you, I hate these medically sophisticated groups of people. Yeah, even this room is spiked with healthcare people. So the question was whether ACTH for infantile spasms can have an effect on any of these things, and the answer is nobody knows. Certainly, ACTH has effects on the adrenal gland acutely, and weaning of this can be a problem, etc. Right? You're shaking, you're nodding.
4 months old,
Yeah.
like 16 weeks.
Yes.
It stopped his infantile spasms. He went on and had a hemispectomy at 10 and a half months old. He's now 10. We're seeing, I mean, we have major growth issues, weight gain.
That's. I would say.
Early puberty. I mean,
I would say that's more likely the surgery, honestly. I can't say, but I think that that is a constellation that would not surprise me after surgery. Yeah. Yeah. All right. Thanks.